Moving on to a couple of important concepts around this reservoir is something here referred to as the iceberg effect, and that really kind of refers to colonization. So most of us are probably have bacteria on our skin or inside our gastrointestinal tract, for example, so we're colonized with those organisms and they're not causing active infection. The folks that have the active infection, say with a particular bacteria or germ, really represent just the tip of the iceberg. And this concept, I think, is important because there are a lot of residents in long-term care facilities that are merely colonized with multi-drug resistant organisms. They obviously represent a reservoir. If you as the healthcare worker take care of one resident, don't use good hand hygiene, even if that resident has no obvious symptoms of infection, and go to another resident to manipulate a device such as a urinary catheter or feeding tube without using hand hygiene, you can move that bacteria from one resident to another. So this concept of colonization is important because we want to use precautions, especially good hand hygiene, whenever we take care of any resident. And we'll talk about how that impacts interrupting this chain of transmission. So infected, colonized, I'm sure you didn't think we'd be talking about icebergs today, but a useful concept in this picture I think brings it home in terms of what you have on your skin not causing active infection versus those that have active infection process ongoing. So that's the concept of the iceberg effect. Some key definitions of the differences between these two. Certainly colonization means the bacteria is present without evidence of active infection. So it's just on the skin, no active redness, irritation, or swelling, or breaks in the skin where there may be drainage. That would be an example of colonization. Infection, on the other hand, is indicative or indicates a real active infection is ongoing. And that's where the bacteria has gotten into the tissue and actually is replicating, causing damage to cells and tissue itself. So a good example of this would be if you have a resident who's got a break in the skin and there's purulent drainage from that skin cut, then potentially that would represent an active infection, not colonization. Likewise, if you have a resident who has an indwelling urinary catheter, they may complain of, or for example, without an indwelling urinary catheter, if the resident suddenly complains of burning frequency and urgency when they're urinating, that may be an indication of a possible urinary tract infection. So that's an example of bacteria that can be present in the bladder with no symptoms. That would be more of the colonization. When it begins to cause these symptoms of active infection, then we can be reasonably assured that we may have the presence of bacteria into the tissue of the bladder actually causing an actual infection. So those are some useful distinctions, I think, between the concept of colonization and infection. And as I mentioned in the previous slide, the infected, those folks with infection represent just the tip of the iceberg. Most of us have colonization with bacteria. An important reason this is being emphasized is that bacteria that are simply colonizing a resident certainly could be a reservoir and can be picked up and moved from resident to resident during the care activities in a long-term care facility or nursing home. So moving on to, we've got the kind of the infectious agent. We have a place where it's growing and replicating. How does it leave that person to get transmitted? There's a mode of exit. So that's the organism or the germ has to leave that one resident and somehow move into the environment or be moved to another resident. And how does that happen? Certainly here's some examples of that. So respiratory tract, if I have acute influenza infection and I cough or sneeze, I can release that influenza virus up into the surrounding area, usually within probably 3 to 6 feet away, and can release the influenza virus into the environment. So that would be an example of kind of release or exit of the organism from the person with the infection. Gastrointestinal tract, certainly if you've got a resident with acute vomiting, nausea, and diarrhea, that's another way for this organism to get out of that resident's body into the environment around that resident. So that would be an example of the gastrointestinal tract. Skin and mucous membranes certainly would be maybe we have an acute skin infection where there's drainage. Again, that bacteria in the drainage, there's a lot of microbes or germs present that can be released into the environment. Genitourinary tract, certainly blood, if you're doing blood glucose measurement in a long-term care facility and the lancet's contaminated with blood and it's on the tip of that lancet, then there would be a potential mode of transmission in that situation. So it's left that person's bloodstream and is on a contaminated device. And then artificial openings such as a tracheostomy or let's say we have a feeding tube in, there's certainly a way for bacteria under the skin or in the skin structures to get up around that catheter and be released into the environment. So those are the modes of exit. Even with that kind of release of the organism from the resident that might have the infection, we have to have a mode of transmission. So it's got to be moved from one location to the next before there's really kind of this piece in the chain of transmission to begin to complete this chain. So the mode of transmissions that we most commonly are focused on are really contact transmission, and that's got two modes. One would be direct, where I'd have direct contact, say with a draining wound. That would be an example of direct contact. Indirect might be the surface around that resident. Let's say the bed rails on their bed are contaminated with microbes. The healthcare worker comes in to do some activities of daily living with the resident. They touch the bed rail, don't use hand hygiene, then go to another resident. That would be a mode of transmission of kind of indirect contact. Droplet, I mentioned earlier about influenza. It really is coughs or sneezes is where the influenza virus is present. So if you're in a close proximity to somebody who's coughing and sneezing, and probably 3 to 6 feet away, that's where we would see the mode of transmission really through the air, but for very short distances, probably 3 to 6 feet. And then third most kind of typical mode of transmission would be true airborne. An example that we can point to very nicely is tuberculosis. So somebody who has active tuberculosis in the lung coughs quite a bit, and then they're producing the TB bacillus is actually getting up into the air. And what's unique about TB is it actually gets suspended in the air. So it could travel fairly large distances through the air from one room to the next, even through the ventilation system. So that would be an airborne disease transmission. For most of the residents in long-term care facility, and actually for that matter in acute care hospitals, we're really focusing on contact transmission in terms of the mode of transmission. Most of the organisms or multi-drug resistant organisms are actually picked up on our hands and moved from one resident to the next or one patient to the next.